Hi, everybody. Good evening. Welcome to EduTALK. EduTALK is a weekly virtual talk show, and it's created out of the need for a global learning community. And we focus on topics that are relevant to us today. EduTALK happens, as I said, on a weekly basis. And today we're featuring Dr. Priyanta Ravi. I can't pronounce her middle name, and she will pronounce that for us, but of course I got those other ones correct. So Dr. Ravi is joining us from New Zealand, and she has degrees in neurology, Alzheimer's diseases. So this is her research. So she's a doctor of medicine, and dementia is one other area, neuromodulation, and so on. She also has a MBA in finance, and done a whole lot more areas in medicine, such as integrated pain medicine, as well as medical distribution. And then on the other side of things, she's an entrepreneur, and we're going to talk a little bit about that before we get into the two areas that we're focusing on. She is a founder of this company called Vichy. I think you pronounce it like that, Vishesh. Pranta, yes. Welcome to EduTalk, first timer from across the pond, as they say.
Thank you so much, Dr. Dice, for having me. It's my pleasure.
All right, good. So let's give our viewers a little bit about you. If somebody would see you, walking up on the side of the road and say, "Hey, what do you do?" You look like a medical person. What would you tell them?
I normally just say I'm a neuropsychologist.
Okay, and stop right there.
Yeah, stop right there.
A neuropsychologist. All right. What caused you to be in this field of medicine?
Well, initially when I was younger, if somebody said medicine, then you just talked about, your family doctor. So for a long time, like most of us, I used to think that if you want to study medicine, then you have to be a family doctor. But then as I was more interested in science and I studied a lot more in school, and, I started realizing that actually there are more pathways, you can specialize and there's a lot more different types of doctors available. So that's basically made me decide that I'm not going to follow conventional medicine. I'll do something different. So quite early on through school, I had a lot of exposure to basically understanding science, biology, what happens in the brain. And I just sort of thought to myself that, hey, this is really cool. I want to understand the brain a little bit more. So that kind of planted a seed in me of curiosity. And through university, I thought, yeah, this is fantastic. This is great. And while I was doing my undergraduate, I was working as well. So when I was working in GP practice, I realized that this is really good, and there are days where you can get very, very chaotic. But I felt after a period of time that I got a little bit bored and everything was quite boring. You feel a little bit restricted because you have to wait for a number of other things to happen before you can actually take some action. And
Right.
I thought, it's good for interim and to practice and build a lot of soft skills. But in the long term, as a career, I don't want to switch off. I have to constantly be jumping. I want to make my money by, literally putting in some blood, sweat, and tears.
Yeah, that's very good. Tell us a little bit about the neurologics. Neurologics, you pronounce it? Um,
Yes.
did you create it, or because this is neuropsychology, which is with pain and spine s- areas of the body, and you're a specialist in that area, and you have studied at Harvard for this in this area, this field. Tell us a little bit about it.
Sure. So
Yeah.
the concept of neurologics was that we wanted to introduce something called neuromodulation, particularly in New Zealand.
Mhm.
Now, it wasn't substantially new. There are different forms of neuromodulation, which I'll chat to you about a little later.
Right.
But the idea was that we can try and use neuromodulation, particularly non-invasive forms, and use that as a first line of treatment for a number of conditions and issues.
Mhm.
So in New Zealand, I didn't find any kind of institution that could offer me that kind of training. So I started looking online, doing a little bit of research, and Harvard came top level in terms of doing courses to subspecialize in that. And I joined up for that. They were very generous in terms of, accepting me and literally walking me through the program. So that was really good. And till date, we, manage quite complex webinars, which are very intense, but also very humbling because we've got a whole network of global experts that join us. And we are basically discussing things in terms of, where each one of us is going to take this approach in terms of our different specializations and areas. So the idea behind Neurologics was that we're not just going to focus on the brain, which is just sort of looking at the person's head. We're going to actually focus on the entire nervous system. And that's where pain becomes very important because it's your nervous system that deals with the pain. So sometimes it's got issues with an injury along your nervous system in your hand, which is the peripheral nervous system, and that communicates pain in the brain. So that is kind of reverse engineering, not just limited to what's happening inside the actual brain structure, but what's happening in the wider network and how we deal with things like pain and different kind of symptoms that occur throughout different nervous systems and the subsystems within that. So that's where neurologics came about, and that's the idea, basically, whether it's got to treat non-invasive, cognitive symptoms or conditions and disease and illnesses, or particularly pain in people, which seems to be quite chronic. And a very big issue in the sense that there's medication available, but we find that over a period of time, people don't really get any effects, mostly because the system becomes immune to it, but also because of, changing body types,
Mhm.
different lifestyle factors coming in, So with medication, we find that there's definitely temporary relief, but
Yeah.
it doesn't actually solve the problem at the root. So that's where neuromodulation is really helpful because you can actually target the systems that are causing the issues rather than just dealing with the symptoms
Right,
themselves.
right. So neuromodulation, because that's we're getting into the topic that you're focusing on. Neuromodulation and dementia. Can you go over what neuromodulation is a little bit more and then tell us a little bit about dementia as well. And what we're getting at is the importance of this, especially now, at present. It's very important that people understand because dementia is on a rise among
Yeah.
people in general. So give us a little bit about neuromodulation, a little bit more, and then dementia.
Sure. So neuromodulation basically is playing with the brain system, So the technology is you're stimulating the brain either using magnetic waves or using, some form of mild, not electrocuting, but mild
Yeah.
electromagnetic waves as well. And the concept is, you're basically massaging the brain or putting in some form of energy into the different brain systems in the peripheral nervous system to say that, hey, look, wake up. So the very common thing that a lot of institutes and I guess professors use, and I certainly came across it to teach us about the brain, is how brain behaves. So the brain is made up of neurons. You might see a diagram of it where it's looking like, sort of like an egg yolk. So you'll
Mhm.
have a center, which is the neurons, nucleus, and then it will look like, the white, sort of like a sunny side up egg, if you
Mhm.
want to look at it, which will be periphery. So what happens with the neurons is they talk to each other through chemical signaling, and that happens through ion channels. But what happens is neurons, when they're connected to each other, whether physically, structurally, so they might be joined to each other, or they might talk across a distance, which is functional.
Mm.
So when they don't talk to each other, they're not active, they're like, oh, I don't have anything to do. And over a period of time, when you don't stimulate them, they start dying off.
Oh,
So what professors say is, for your brain, you use it or you lose
oh,
it.
is it right,
And
right.
that's exactly what we see, in the face of different kinds of brain pathologies, that somehow the disease disrupts this dialogue or prevents neurons from talking to each other, being active when they don't receive stimulation. That's when they start going downhill. And if the neurons don't work, whatever their role is in the brain, whether it's for
Mm.
memory, whether it's for speech, whether it's for language processing, you don't get that. So what neuromodulation basically does is kind of give a little bit of a wake up call to the neurons and say, you know, get up, you're still alive, give them a bit of energy, motivate them.
Yeah.
So that is what neuromodulation does, and it harnesses on a feature of neurons, which is neuroplasticity. So neurons, they change themselves. The brain has its own immune system. So the neurons are very different to every other kind of cell type that you'll find in the rest of the body.
Mm.
So it doesn't need, your immune system or your white blood cells that are sort of in your guts and intestines to come up and clean it up and do sort of repair and regeneration. It
Mm.
has a feature called neuroplasticity where it can self-repair. So
Oh,
if you keep it alive, if you keep using it, stimulating it, it will self-repair. You can get new neurons, the damaged ones will be replaced by newer ones. And that's how you
interesting.
maintain healthy function. So neuromodulation basically allows neuroplasticity so the brain can sort of regenerate itself.
Mhm. That is really interesting. What when you mentioned that the brain has no white blood cells, so because white blood cells when you have an injury and they come around like the
Yeah.
soldiers and they protect everything and they cured everything and they heal it. And if the brain doesn't have that as part of the body, you said it has the its way of taking care of itself. Talk a little bit more about that, the healing part of the brain.
Absolutely. So if we have any sort of wound in the rest of the body, you will obviously have some sort of inflammation going on. There might be bleeding at the surface. Say, for example, if you have a cut on your hand, then you're obviously going to have blood loss. But below the surface, you'll have the white blood cells coming in, the platelets forming to kind of
Right.
block the blood from coming out and stop the blood loss. And then over time, your immune system will send different repair cells to say, hey, look, if there's any bacteria, any kind of unwanted foreign substance,
Mhm.
attack that, get rid of it so the body doesn't become sick, but also start the repair program. We need new skin barriers. And over time, the wound heals, right? Um, Same thing for any other area. If you have an internal injury, say your organs, same system. It's just that we can't see it. It's more closed. With the brain, we have something called the BBB, which is the blood-brain barrier. The blood-brain barrier is so, sophisticated that it doesn't really allow a whole bunch of things other than blood
Mhm.
and, the nutrients in the blood that's going in. So what internally in that ecosystem inside the head happens is we've got something called macrophages, and
Mhm.
the macrophages, very little, but they're part of this family of cells called glia and microglia. And what they do is they clean up the brain. So, like we said, if there are cells that are not working, that are damaged over
Mhm.
time, or there's some kind of toxins that have been formed in the brain for whatever reason, they clean it all up. They clean
Okay.
it all up. But you don't have the same immune system that's, you've got multiple types of cells and the white blood cell category that can come
Yeah.
up and fight infections and things like that. So that is why the brain is far more sensitive. But also because your first line of defense is actually your white blood cells, the things that you consume. So the first line of defense for immunity in any case when we're looking at disease through viruses or pathogens is, the intestine or the gut area, gut health, the bacteria and microbacteria there.
Mm-hmm.
Internally, the system that we have for the brain is just to deal with brain health. So when there's a problem, if we have inflammation in any other part, it's like, for example, if you have an injury somewhere else, you might get some symptoms throughout,
Mm-hmm.
your body. So, for example, we know that when people go through different kinds of injuries, they might feel, fatigued.
Right,
That's
right.
one kind of, symptoms. You'd report be feeling tired, or if there's a lot of blood loss, you
Mm.
might feel weak, low in iron, something like that. With
Yeah.
the brain, we don't get those symptoms. Okay, so if there's a problem, if there's any kind of inflammation within the brain, we cannot track it. And that's where it becomes very important that we try and see what's happening inside the brain. And that is only possible if we can scan the patient. So, preferably if you can do something like a PET scan or even an fMRI, and
Yeah.
that can actually tell us if there's bleeding inside the brain, if there might be a blood clot.
Or a
Um,
tumor. Mhm.
or a tumor. And that's very important because with tumors, sometimes they don't show up in terms of symptoms. The person may not have a lot of
Right,
symptoms,
right, right. Yeah.
and but the brain would be really inflamed, you know? Because of the issues that are happening inside. So that really makes it very important, and even for public awareness,
Yeah.
that just because you might not have symptoms for something doesn't necessarily mean that's not a problem. So what we're trying to do with neuromodulation, along with, different strategies, is that I work very closely with international teams trying to develop clinical frameworks and treatment strategies, both in terms of non-invasive neuromodulation,
Hmm.
and these approaches are very important for neurodegenerative diseases like Alzheimer's and Parkinson's, which are sort of underneath that umbrella of dementia.
Hmm.
Because by 2030, Alzheimer's cases will exceed 75 million worldwide.
Wow. That's a
So
lot.
yeah, that is a huge, huge burden, in terms of caring for these individuals, especially with dementia and many forms of dementia like Alzheimer's.
Hmm.
Once you exhibit, a certain or you meet a certain threshold of cognitive decline, there's no going back. So the
Yeah.
decline after that point isn't gradual anymore, it's quite sharp. Um, so you need something that can kind of, make that decay steady, if not reverse it.
Yeah.
So it's
Let
really important.
let me ask you this before you get into the examples of dementia. What exactly is dementia? And talk a little bit now, because you mentioned Alzheimer's as a form of dementia. So
Yeah,
roll back a little bit and talk a little bit more about dementia itself. What is
sure.
it? Because I personally don't know 100% of it. I heard about it and I've seen the effects on people. So what exactly
Mhm.
is it?
So, dementia is an umbrella term. It's given to basically neurodegenerative diseases.
Hmm.
Um, and Alzheimer's is probably one of the most common, dementia out there. And the next one following that is Parkinson's disease.
Okay.
So, what happens in dementia is basically there's an issue within the brain where separate parts of the brain cannot talk to each other.
Hmm.
And that means that your brain functions or your cognitive abilities. So your cognitive abilities are things like speech,
Hmm.
reasoning, memory, which is very important. That means all those things will not perform very well, or you will not be able to function them.
Okay.
So that is why some of the key symptoms of dementia put together is that you'll have memory impairment, you will have at some point difficulty processing language, or you lose the ability to speak yourself, and also cognitive reasoning. So sometimes we feel the person does speak, but they may not be able to understand things.
Okay.
They lose the ability to tell right from wrong. Rationality doesn't work because probably somewhere in the frontal lobe, which is sort of the front part of the brain, for those who are not very familiar with brain anatomy. That is the region that's involved in, reasoning, thinking, critical thinking, analysis.
Right,
So
right.
this problem there, then those patients will have a very hard time making very basic decisions. And it may always seem like, if you know the person personally, you feel like there's a change in their personality. Why is this person who was always very calm, very mature, behaving in, almost a silly way?
Yeah,
So people don't get to actually realize what's happening because the symptoms are actually, in a way, very well masked. So, frontal lobe dementia itself is quite common in a lot of people. So, within Alzheimer's, there's a different variety. Everybody has different kinds of pathologies that exhibit the same condition.
yeah. How do you know what because if you say that some of them the conditions are masked with a type of symptom, so these
Mhm.
symptoms are very different. How, as a medical person, you diagnose somebody and you leaning towards accuracy that this is Alzheimer's as compared to this is the onset of Parkinson, or the person just probably need rest. How do you
Mhm.
determine that, and how long does it take for you to do a proper diagnosis?
Right. So, as a go-to, there isn't a benchmark right now internationally for making a clear-cut diagnosis for any form of dementia, including Alzheimer's.
Yeah,
But there are cognitive tests, so it's more psychological. What actually happens is if you want to find out if a person has any form of dementia, and see, this is the I guess issue that we're trying to change is that when you present yourself to the doctor, obviously a lot of time people don't have any awareness or they may
yeah,
not be able to pick it up. Some people don't understand anything about dementia, that this could actually be a disease. So you would not really actually present any concern to say that I think I might have this
mhm,
because you don't know.
mhm,
But when that happens, there is a sort of approach where your family doctor can then, monitor you and just ask you to do a bit more tasks, maybe make some lifestyle changes just to make sure that it's not stress related or something temporary.
right.
Um, that takes a bit of time, you
Mhm.
know. It can take 3 months, it can take 6 months. It depends basically how well you communicate with your
Yeah,
family doctor.
yeah, yeah,
But eventually, if there's a point where you feel like, I'm losing it completely, or your family may accompany you and they say that, we've noticed a lot of changes and we feel that there's something wrong, then the doctor can then do a cognitive test. So there is a benchmark cognitive test where it's basically a psychological assessment. It takes about 45 minutes. It's in English and it's a bunch of tests that basically tell the doctor whether your cognitive abilities are intact. Can you, sort of like a mini exam, Can you read? Can you write? Can you do basic maths? Is there a problem with your memory? But the problem there is a lot of the family doctors that we have, not just in New Zealand, not just in Australia, but worldwide,
mhm.
don't have that 45 minutes time to sit with a patient to do it.
Okay,
And although that exists, in reality, nobody ever goes that far. So what happens is the symptoms become sort of, nothing is there to interrupt them.
yeah,
And also, if the person is a little aged, a
mhm.
lot of times the families think that, oh, it's just normal aging. You're getting old.
Yeah, yes,
That's like
yes.
you're forgetting things.
Mhm.
So really, sometimes they kind of take a step back and they don't really show a lot of awareness or proactivity about finding out more. If we had a good alternative, for example, if we could have a system where we can do some sort of scans that would actually tell us if there's something wrong with the brain. At least if, there are areas that are not working, areas where there might be an injury, where you're not getting blood flow, where you're not getting oxygen, that would be much better than, waiting and seeing if the patient sort of improves over time or sitting down and doing a 45-minute test with them because not everybody understands English.
Right.
Not everybody,
Yeah.
understands uh, or can read and write in English, especially in different cultures, where aging population, they're very fluent in their own language in
Yeah.
terms of writing it and speaking it, but you wouldn't be able to administer the test. So there's a limitation to that. So not only is it less common because it's very time consuming, which is why a lot of times that diagnosis isn't officially made. And
Yeah.
the patient is only sort of retrospectively diagnosed when you reach a position where they basically cannot function themselves. They're no longer independent. And
Mhm.
then they say, okay, now you're exhibiting major red flags for dementia. So it must be dementia.
Oh,
Exactly.
yeah, I'm looking at and listening to you is in other words, people are supposed to be vigilant about their health in every way,
Absolutely.
brain and body alike, in order to see the even before the decline, you start
Mm,
seeing some changes. How does sleep work with this sort of brain activity? Because some people say, oh, well, I don't get enough sleep. I'm tired, but I'm working through my job and I go home and I get 4 to 5 hours sleep. I'm okay. How does sleep does sleep play any role in all of this?
absolutely does. So basically, what happens when your body goes to sleep is your rest of the organs, they start detoxing. They start cleaning up, Okay, this person is not eating. I don't have anything to do anymore. Let's clean up. Let's
Okay.
tidy up. Let's repair cells that are not working. What's broken can be fixed. What's dead can be removed. What new cells need to be made. We'll start all of that. The same thing happens with brain. So along the same lines of neuroplasticity, and again, this is the golden function of neurons,
Mhm.
is that when we learn something, whether it's a language, doing normal tasks, we need our memory, right? So
Yeah.
learning and memory go hand in hand.
Mhm.
If we don't get enough sleep, whatever information we're carrying in our minds doesn't get consolidated. So memory is quite sophisticated, which is why, till date, a lot of experts and scholars can't really say definitively that this is exactly what's happening on or where in the brain it's happening because it's
Right.
not localized to one structure. But we know that the hippocampus is quite involved in forming memories and just looking after that, portfolio of memory. So, but broadly speaking, memory has three components. You'll have your short-term memory, your long-term memory, and your working memory. So your working memory is basically like a holding ground, So you might have picked up a new information, say, for example, a phone number,
Mhm.
that you might have said maybe 5 times today or written it down while speaking to somebody over the phone. And then you might have repeated that number to somebody else. So you probably said it 3 times and wrote it down 4 times. That might be in your working memory. Now, if that number is important for you, um, it will be in your working memory, but if you do it again tomorrow, give it, read out the number again to somebody else, pass it on,
Mhm.
then it gets stronger in your working memory. So the more times you repeat it, both verbally or writing it down, as long as you're processing it in your brain, the higher number of times you repeat it, the stronger it becomes in your working memory. So it gets held there. And when it's strong enough, you've repeated it enough times, it goes into your short-term memory. So when it transfers into your short-term memory,
Mhm.
um, it means that you might not say it every single day, but if I ask you 2 days later, hey, Dr. Dice, can you tell me what that number was? You'll remember it. Without writing it down, without looking at something, you'll remember. Why? Because it's strong enough to go into your short-term memory. Now, if I ask you to not look at that number, not repeat that number, and just leave it as it is and test you a week later, you may or may not remember, depending on how good your memory is.
Yeah.
But the idea is when you stop doing something and I guess the memory hasn't consolidated enough or it's not strong enough, you'll forget it. But it will still be in your short-term memory. You'll be able to remember it as long as it's relevant to you.
Mhm.
But if it's no longer relevant to you, it basically gets deleted from your short-term memory and doesn't go into your long-term memory. So the same thing happens with events, if something is very dramatic or very strong, it has a lot of emotions attached to it. It could be very sentimental. You'll
Okay.
remember it long term. So, for example, a very nice childhood memory.
Mm-hmm.
So those memories that have a lot of affect or any strong emotion attached, negative or positive,
Mm-hmm.
they tend to hold on longer. So that is why you remember things from your childhood because they're so strong. You've gone through them so many times that
Yeah.
it's transferred from your working memory to your short-term memory to your long-term memory. And when it goes into your long-term memory, you don't need any cues to remember it. You just
Right.
know it like that.
Yes. Yeah. Yeah.
So it's the same thing with learning. So a tip that I found very useful, and if you're a student or you're sitting exams,
Mm-hmm.
what you should do is if you're reading something and you want to sort of learn it, not necessarily memorize it word for word, but learn it,
Mm-hmm.
um, read it or paraphrase it, write it, whatever works for you. Go through it a couple of times
Mm-hmm.
and then sleep. Sleep for 15 minutes, 20 minutes if you can. Take a nap or do it before bedtime.
Yeah.
When you wake up in the morning, you will remember it because
Wow.
at night, that is when the brain shelves everything in your, whatever has happened, whatever information it has developed or it has gotten, it processes that. So whatever is not relevant, that you don't need, or is no longer required or used, it gets chucked away, because the brain doesn't have fixed storage, kind of like iCloud.
Mm-hmm.
Yeah,
Yes.
or your Google Drive. It
Yes.
doesn't have fixed storage. You can't simply buy more storage.
Yes.
So when you sleep, this is really important. It's not just replenishing your cells, but it's actually replenishing your cognitive function because all of the information is dealt with by your memory. And when you process that information, and if your memory is really good, if your sleep is really good, then you wake up feeling a lot better.
Interesting. Oh my goodness. Give us, because we have a few more minutes. Let's talk about the work that you do, the
Mhm.
and the advances that have happened in the work that you do. Yeah, talk about the work because you have a lot going on in New Zealand and Australia, and I think it's
Yeah,
really fascinating to share.
absolutely.
Yes.
So I'll highlight some of the research that's both published and emerging that both myself and my colleagues internationally are doing right now. And basically, it shows how mechanical and electromagnetic stimulation may influence and sort of enhance neural regeneration,
Mhm.
synaptic repair, and overall cognitive resilience. So to begin with, what we're saying is yes, we've got pharmaceuticals, we've got medicine, traditional medicine. They can definitely buy time. They can help support, remove the stress or the burden of the symptoms on the patient. But we know that over a long period of time, the effects have plateaued. So it doesn't really benefit the patient after a point. There is a plateau, there is a threshold where it's just not going to be of any use, or there are cost factors, people may not access it. So how non-invasive neuromodulation works is that it basically taps into neuroplasticity. And the three modalities that I'm going to cover in terms of how neuromodulation can tap into neuroplasticity. So the first one is mechanotransduction. This is your neurons responding to mechanical force. So it can be, like I said, gentle kneading that wakes up the signals and kind of helps the brain to stimulate itself, repair itself, and kind of stay alive.
Yeah.
And the electromagnetic fields and ion channels are very important because when they're active, when they're stimulated, they open doors for growth and repair.
Mhm.
So it's very important to, keep it alive.
Yeah.
Um, so we know that calcium function or calcium signaling, how brain talks to each other using calcium channels, is very important in neurogenesis,
Okay.
which is basically just, the neurons generating new cells. So if we have any kind of damage, whether it's through injury or assault or for any kind of reason, actually, sometimes, the cells mutate, there might be an issue in producing a healthy cell, whatever it is.
Mhm.
If we get rid of that, we need healthy cells to replace it
Yeah.
in order to keep up the function. So calcium channels are very important in neurogenesis. And the outcome of neuromodulation, they're non-invasive. So the key is non-invasive. We're not doing any surgery, which is brilliant.
That's good.
No downtown in hospital. It's not scary. Even surgery is very risky for the surgeons because it takes a lot of time. It's a lot of,
Yeah.
skill, very
Yeah.
minute work,
Yes.
making the skull open. A lot of risks as well. So if we can minimize that, it'll be a huge sort of bonus for the patient, but also for the surgeons, because really, while surgeons are trained in doing neurosurgery, they
Yeah.
cannot spend hours and hours, one neurosurgery, anywhere 5 to 6 hours. It's very intensive. So they cannot do too many, a day. So that is why non-invasive neuromodulation is really, really helpful because we can avoid unnecessary chopping and cutting up.
Yeah. Yeah. Definitely. Yeah.
And we can get stronger, cognitive function.
I hope this is very helpful to people because when they think of medicine or any problems with their body, they're always thinking about, okay, I need to open this patient. I am gonna get opened up and I'm going to get fixed, and then it's gonna leave a
Mm.
scar. So a lot of time. So no, you're saying that you don't have to have a scar and you could get fixed and be back to normal tomorrow morning.
Absolutely. And that is why the key modalities that I'm going to talk about, the three modalities of
Yes.
neuromodulation, are very important. So, what it does is without any invasive cutting, chopping, or actually just putting you into that fear, because it is, a lot of people who've gone through surgery, it is very scary,
Yes. Yeah.
Without going through that, how can we actually reverse some of the issues happening in the brain by rewiring it or reprogramming it?
Mhm.
That is what these three key modalities do. So the first form of neuromodulation is something called shockwave.
Mhm.
Basically, it uses focused acoustic pulses, and again, it stimulates the brain.
Right. Right.
So we've got IRB pilot studies that have been going on globally.
Mhm.
And so the technology and the devices have existed for a very long time. So we've had neuromodulation exist since the 70s and be practiced very
Rightly.
prominently.
Yeah, yeah.
Yeah. It's just that over time with different kind of technologies and also understanding how the brain responds to stimulation, we've been able to fine tune, and kind of get better enhanced function through the different technologies that are coming out. So that is why this is a really exciting space. So shockwave is one of those where we get focused acoustic pulses. So that means if the rest of the brain is fine, but it's only one area that needs a little bit of a, stimulation, then
Mhm.
we do shock waves.
Okay.
And it's just only going to stimulate that area because
Oh,
the rest of the brain is working fine. So you don't want to give it more energy, more stimulation, because then that's also going to be problematic,
okay.
right? That part, you don't touch the bit that's working fine. We just focus on the area that's a little bit of an issue. So then we've got pulse magnetic fields. So we've got EMF and ENTT. So EMF is again your electromagnetic field, but it's focused, which is why it's MF. And then we've got the same thing with ENT, where it's not focused, it's more radio.
Mhm.
And we've got a lot
Okay.
of brain trials. Brain trials are, showing different kind of results for, again,
Mhm.
focused. There are certain conditions where you'd start off maybe using focused, stimulation, and then you might go into pulse,
Okay.
depending on how the patient is responding or the brain is responding. So it's about using a combination of technologies based on the recovery. And there's definitely brain trials, but I will also let you know that there are a lot of my colleagues that are using it for, again, outside the brain for different conditions. Um, and then there's neuronavigation. So neuronavigation is the newest one to arrive on the block. It's image guided, and it has been very commonly used in animals to basically scan the brain, have a image, like I said earlier. And then based on the image, if we can say, which area needs the stimulation, we can do guided stimulation for that area and basically decide how much intensity and how frequently we're going to stimulate that. So that is also coming up, and we've got amazing clinical research in humans as well, but it's still quite ongoing.
Yeah. How is the popularity of it in your area? In New Zealand and Australia coming up to like maybe um Africa and Europe and like in England or so on. How is it going with the information spreading about this type of medical research and availability?
Yeah. And that's where, my colleagues, the international team that we have, they
Yeah.
play a very, a strong role. When I speak about New Zealand and Australia, yes, shockwave exists, neuromodulation exists, and it's applied mostly for physiotherapy,
Mm-hmm.
for chiropractics, sometimes in combination to treat different kind of conditions, but also orthopedics. So I've got a lot of sports clinics that I've seen quite commonly in Australia and less commonly in New Zealand. Here the issue is how you're going to sustain the cost, I guess. So that is where establishing it as a first line treatment becomes a little bit tricky. But
Yeah.
that is what we're working on in terms of having different clinical frameworks. But it's not completely absent. So it is there, it's working. We've got different sports clinics that are basically using neuromodulation to treat, issues with injuries in the ankles, whether it's knee, treating people with, different kind of sporting injuries, whether it's got to do with their shoulder, so
Yeah.
that they can have more movement, get rid of inflammation happening at the joints. So that is happening. What are we trying to do is we're going to try and refine some of the approaches is basically what we're coming from, because some of the devices that are being used in these sort of markets are still very conventional, and we find that the frameworks are conventional, so they might be doing the same stimulation for the patient for a very, very long time and notice that after a point, this patient doesn't, improve. Or the improvement is kind of regressive in the sense that you
Yeah.
go into a relapse, whether
Right,
it's
right.
through, not having that movement again. So that is why we need those clinical frameworks and to kind of have more refined treatment protocols where we can respond better to the patient and the patient's body to the treatment. So sometimes you need to start off with maybe slowly and gradually build it up and then let the patient and the body kind of adjust it. And once it's
Yeah.
stable, you might want to change it a little bit more. You might want to intensify it. It's never a good idea to start up very high and then keep giving high shocks, because
Right.
the brain takes, even whether we're looking at cognitive conditions or anywhere else in the nervous system, peripheral nervous system, it takes time to adjust. It otherwise is just like, what's happening to me? It can get very confused.
Yeah.
So it is very important to have that. So I've got a colleague in Denmark, Michael Strom, and he's a pioneer in shockwave. So he's been using shockwave and guided shockwave using ultrasound as well in combination to treat, scar tissue from injury and to correct circulation, which is very important in men's health and in pelvic pain.
Yes.
So what Mikhail has been doing with his work is he's been applying shockwave for specific conditions in men's health as well as pelvic pain. And he's the champion that, which device, which intensity, he does that combination,
Oh,
the
wow.
layering that's really important. And so aside from his clinic work that he's doing in Denmark, he's also, establishing these benchmarks as the standard line of treatment through shockwave. So
Mhm.
he's a, great person to check out if you're really interested in how you can, choose which devices,
Yeah.
different intensities, to get a more refined treatment and get the results actually. So he's a very wonderful champion of using that, and he's in Denmark. And
Yeah.
then I've got a colleague in Scotland, Helen. So Helen Howe is a orthopedic doctor in Scotland, and she uses shockwave. So shockwave, in terms of her main work, used to be using EMFT and EMTT, like Michael.
Mhm.
in Denmark, and basically she applies that to orthopedic conditions.
Okay.
So Helen has shared a lot of research that she's done personally, but also as part of a wider clinical team, both in Scotland and the global population.
Mhm.
And she works extensively with sports players and professional level athletes to correct their injuries. And
Yes.
what we've found is that when we apply shockwave, especially a combination of EMT and EMFT,
Mhm.
we get better recovery, more recovery, better recovery than what we used to get from saying just physiotherapy alone.
Right. That's my question that I was gonna ask.
Yeah.
Okay. Yeah.
So she's working very hard with her colleagues in her region to basically implement this with other sort of treatments and therapies that sports people use. And
Mhm.
she's often shared, and published as well, athletes that are, competing for Olympics,
Yeah.
and other very prestigious kind of events that are happening globally, where they've had an injury and they just cannot get back up, and they come to her and they say, "Look, Helen, I have tried a lot of things and it's not working. The pain keeps coming back, or I can't recover, and I'm very stressed because I want to go and play. I want to participate in this event." And she's gone through these treatments with them, and the final result is really astounding because the way she has done the work and the way she has documented the clinical evidence, we
Mhm.
see these people then actually not just participating in these events, but winning. We have had
Yeah.
athletes where she has treated a lot of women with, shoulder injuries, back injuries, spine injuries, leg injuries, knee injuries, and these women in a very short period of time have recovered miraculously and brought home gold medals. And
Wow.
that is amazing,
Yeah. Yeah.
without putting a lot of pressure on the brain and having the person fatigue and burn out mentally as well, because athletes go through a lot of mental processes and stress as
Yes.
well.
Yes.
Performing,
Yes. Yes.
um,
Yes.
it, and when we speak to some of the people that she's worked with and she shares, their feedback, it's
Mm.
amazing because they say that, this has been very instrumental in terms of giving them confidence that,
Yeah.
your body is going to respond to what you want to do. So Helen is amazing there in terms of the work that she's been doing in Scotland. Closer to your region, I've got a colleague called Boris. He's in Florida.
Okay.
So he uses a combination again for psychological application to spectrum disorders like autism.
Mm.
Um, for treating something like dementia right now, especially in America, it's still considered off-label because we're still finalizing all of the clinical trials for
Yeah.
FDA approval.
Yeah.
But device itself is, the devices themselves are approved, so they're safe to use. So while sort of we getting that final approval from FDA for,
The
using it in
trial.
dementia,
Yeah.
Boris is using it off-label, but he's certainly using it for things like spectrum disorders like autism. And he also shares quite actively the results that he's found in his patients, particularly in young children, who
Yeah.
have had very sort of severe cases of not just autism spectrum disorder, but also the anxiety levels that these children have. So he's found that by layering shockwave and using the applications, whether it's EMT or EMFT, he's found that these children work much better. They're a lot calmer. They can learn much better. They're
Mm.
more confident.
Mhm.
Their symptoms are easier to manage. And it actually helps with their brain development as well. So, really, you're trying to reverse the pathology of the disorder. So, if we can catch them early and we can start going through the treatments, really, we can minimize a lot of the effects or
Mhm.
the cognitive effects that actually have on development for people who have autism spectrum disorder before it gets to the brain, to the level where
Right.
you can't rewire the brain. So we know that with children, especially with, the literature that's there, both in terms of clinical, but also theoretical scholar literature, the younger you are, the easier it is to reprogram your brain because
Yeah.
neuroplasticity is very high.
Yes.
As you age,
Mhm.
and if you add in, a stressful lifestyle as a factor, your ability to neuroplasticity or to basically generate neurogenesis declines. So if we catch them early, it's really good. If for some reason the patient, even say with dementia, happens at a later age, That's
Mm.
still fine, but the sooner we get it, before a lot of the pathways become implicated, the better it
Yeah.
is because we have then better outcomes or better chances for better outcomes with the patient. So
Yeah.
he's now working with Harvard Medical and also University of Florida, and they're doing off-label treatments for, basically trialing dementia and Alzheimer's disease with shockwave. So there's a lot of research that's coming up there as well. And they're doing it locally through the United States, which is your
Yeah.
region.
Yeah.
And then when we talk about dementia, which is how we started off,
Right.
we've got my team in Switzerland called Stores Medical. So Stores Medical is a very, very prestigious company. They specialize in manufacturing different kinds of, medical devices,
Yeah.
and they have something called the TPS, which is the transcranial pulse stimulation machine. So TPS is the only specialized neuromodulation device for dementia in the world. So this is
What?
not just for any kind of shockwave, but this is specifically just going to focus on the brain.
Yeah.
So my team there, Manfred and Thielen, they're in Switzerland and they have implemented quite
Mhm.
successfully TPS in the European region, particularly in the United Kingdom. And they're now moving to partnering with universities in South America and a lot of universities and private clinics in Southeast Asia, including Australia and New Zealand.
Right.
Where we are basically offering this treatment to patients where we can, firstly, we will confirm the diagnosis, whether they meet the criteria. And then, of course, we'll test them to have a baseline measure and, apply TPS. So TPS itself is CE marked, and the clinical trials have been there for at least close to a decade now, where we've had very good results. And the important thing here to note is there haven't been any side effects, So
Wow.
for all of the clinical populations that we've had throughout the world,
Yeah.
we have not had an adverse report of any event, any patient going through a situation.
Yeah.
So the improvement is very, very significant.
It's remarkable.
So
Yeah.
yeah, they've partnered with some clinics in London through psychiatry and wider UK, where TPS has been established as a first line. So I would say they're trying to establish it as a first line treatment, but it's definitely being given to people there, and they've seen the results long term. So we've had patients who have had very severe forms of dementia where their memory and impairment is quite bad.
Hmm.
And after that, we've seen a reversal through TPS, much better cognitive function, much better outcomes, and to sustain that over a long period of time.
Yeah.
So it's very important because in the UK, we have a very strong aging population, but we see that trend emerging in a lot of other
Yeah.
bigger countries as well.
Yes. Yeah.
So that is very promising. So like I said, the device is CE approved, and we're still waiting for the final FDA approval for the global clinical trials, which
Yeah.
should probably complete by 2026.
Yeah.
Um, and that would hopefully establish a benchmark for, TPS as a standard treatment or for dementia and other neurodegenerative diseases, because they're also working with Parkinson's disease. Now, you mentioned to me earlier that what is the difference? How do you know which dementia it is?
Yeah.
So
Yeah.
Parkinson's, we have a very good symptom, and that is tremors,
Okay. Yeah. Yeah.
shaking.
Mm-hmm.
So people who often have very, a mild advanced forms of Parkinson's will have some sort of tremors. So it's involuntary, so they're not doing it willingly, but you will
Yes.
find that they might be, their hand might be shaking a little bit more, their movement might be a little bit more, shaky, and they might have hard time kind of balancing themselves or even how they perceive gait. So their movement has a lot of implications when we look at
Uh-huh.
that form of dementia because the movement chamber, I guess, is very much disturbed in Parkinson's
Right.
disease. So we've seen that, the tremors are a lot milder, if not, manageable, at least for the patient, so that you can control your movement much better. But also the cognitive effects that go with that form of dementia, we have seen better outcomes. So
That's very.
stores have, a number of different trials that they've done, which you can find on their website as well. So you can access information there as well.
Tell us about the website so people can go on there and explore.
Absolutely. So we can share it in the description box. If you're interested, you can have a look at the store's medical website and see the different kind of shockwave devices they have and the different kind of conditions that they have, applied it to, because they've got a wealth of clinical research and they're partnering with different experts. So we've got experts in orthopedics, we've got experts in psychology, in psychiatry, cardiology, basically, and we've got animal studies as well as human studies as well.
Okay.
So it's
Okay.
very much up to date. So if anybody's interested, my recommendation would be that have a look at the websites, and if you feel in your region there's somebody you'd like to connect with,
Yeah.
have a chat to them. Because we definitely have seen that, we need some public awareness about this. Like you
Yes.
said, brain health
Yes.
is
Yes.
important. So if you can
Yes.
connect with the right people, it'll be amazing, because the results are showing that cognitively, people have stabilized for over 6 months.
Okay.
If we look at the small
That's
clinical
very good.
trial,
Yeah.
in
But I
different
wanted
regions.
to ask, do you, when you do the treatment, is a treatment so you have to go back every what, every 3 to 6 months?
No. So how the treatment works is basically usually somewhere between a week to 2 weeks, you will come back for treatment.
Okay.
So, like I said, we can't really overly excite the brain all at once, because especially if there's been a problem or that pathway hasn't been active for a very long time. So
Right.
we have to really slow down a bit, rather than having like a quick fix that, okay, I'm gonna go and do this treatment and I'll be fine within a month.
Right.
It
Right.
doesn't fortunately work that way, because for the results to really set in and to work very well long term, we need to first start off slow. So once the diagnosis and everything is done, we can have an idea that, okay, we should probably start off at a particular threshold. We'll start with regular treatments. The idea is to kind of, have one session of stimulation, whether it's half an hour, 45 minutes. Usually it's between half an hour to 45 minutes or an hour at the max. But after that, we let you go off and let your body kind of, process all
Yeah.
of that activity
Yeah.
and give it time to rest as well. So after a week, if we find that you're holding it well, you're not feeling too tired, and it's going good, then we continue. So usually the therapy sessions are done in blocks. So it can
Mhm.
be, we might want to say do it for 4 weeks and see how you're doing. If
Mhm.
we need more, then we try maybe
Oh,
doing 2 more weeks, you
okay.
know.
Okay.
So depending on when we do the initial diagnosis, we'll probably get a better idea,
Yeah.
whether
Yeah.
it's me or a psychiatrist. We get a very good idea as to what the individual's needs are.
Mhm.
So we might say that overall we're looking at, say, 6 weeks. So that would be 6 sessions once a week. And sort of at the 3-week mark, we might decide to kind of just do a mid-assessment to see how you're coping.
Mhm.
And by the end of the 6 weeks, we might decide that, okay, we're going to stop now, but we'll still, follow up with you just to see how you're going. So sometimes patients go off after 6 weeks and they say, look, this is really good. We're happy with that. So if the patient is happy, we're happy, then we might decide to pause this treatment, and then that's fine. But we'll still keep in touch and follow up with the patient to see how they're doing after therapy as well.
Yeah.
Sometimes we find that, 6 weeks, after 6 weeks, some patients go through a relapse. So maybe 1 or 2 weeks they'll be really good, but then by the third week after the treatment has kind of stopped, they might come back and say, "Hey, actually, I'm getting the symptoms flaring up again," which is quite normal as well. So we
Okay.
might just come back in, and do 1 or 2 more sessions as and when required. So that is the beauty of it, because it's
Yeah. Yeah.
non-invasive. You can
Yes.
do it in an outpatient sort of
Exactly.
facility. And it's quite, confidential as well. So you don't
Yeah.
have to go and admit yourself, if you want to keep it private, you can do all of that.
Okay. Sounds good. We're gonna close it off there. Which is very good. We're gonna have you back on to do some more of this. It's heavy lifting, and I think a lot of people will have to watch the video over and over this show over and over again because of the content. It's very content rich as it relates to these treatments and protecting yourself, your brain, your body, and your health in general. Dr. Priyanta, thank you so much for being on EduTalk. It's been a real pleasure talking with you, and we will talk soon. One of the things I'm gonna come ask you to come back on to talk about is your company too that you start off. It's Vishish. So we'll talk about that when you get back on. Thank you so much. Guys, you want to check out the description. We are going to put the website on the in the description so that you can check out the work that Dr. Ravi here has been doing with teams that she mentioned across the globe. And you can check out that and then see if you see something that you like, you want to connect with somebody, you can connect with them through the website. There's some information there. Thank you for coming on, being with us on EduTalk. We will see you next week with another edition of EduTalk. If you want to write to us at edusolutionsintl@gmail.com, that's edusolutionsintl@gmail.com, or go on our website at edusolutionsintl.org. That's edusolutionsintl.org. Or if you want to just Google us, Education Solutions International, you will find us because we're popular on Google. Education Solutions International. Thank you very much. Have a great week, everybody. Enjoy. We'll see you again. Bye.